All right, welcome to the Maternal Health Innovation Community of Practice. Today's session is titled Best Practices in Supporting Postpartum Families Around Substance Use. And we're so excited to have Dr. Andre Jones and Elizabeth Johnson from UNC Horizons here. I'm going to go ahead and turn it over to them for introductions.
All right, well, I will give first and keep it brief. I am a psychologist by training and oversee the UNC Horizons program. We are a division of OBGYN, which is really exciting. And I've done a bunch of research for many years looking at prenatal exposure to different types of substances that are used during pregnancy, and then also focused on treatment interventions, particularly methadone, buprenorphine, naltrexone, those medications to treat opioid use disorder during pregnancy and the postpartum period, as well as behavioral interventions. And I have the honor and privilege every day of working with Elizabeth Johnson, who is just absolutely amazing. And so I'm going to turn it over to her.
Oh, thank you, Andre. So hi, everyone. So glad you guys are here. Excited to be here with Andre to present to you all. So I'm Elizabeth Johnson. I'm a nurse practitioner by training, have been for a very long time. For the last 10 years, I've been at Horizons. So I do prenatal care for women with history of substance use disorder, the whole range, actively using, some people in long-term recovery, and also oversee the healthcare of all the women and children who live in our program. So I'm going to share my screen so we can get started.
And I will be monitoring the chat. If you have any questions along the way, please do put it in the chat. And then we can ask them at the end.
Awesome. Okay, so you guys can see everything okay? Yeah.
Wonderful.
Okay, perfect. Okay, so our goals that Andre and I have today is to talk about best practices to support pregnant and parenting women with substance use disorders. Think about the use of medications, particularly when it comes to opioid use disorder during pregnancy, and also get into talking about how to support the dyad when we are thinking about neonatal opioid withdrawal syndrome. So just thinking sort of big picture at first, I like to kind of start big and then kind of narrow down. So when we think about substance use in general, so this is for everybody in the United States, it's good to kind of keep in mind that a good majority of people have not used any substances in the past month. So, I mean, there are plenty of people. Sometimes in this work, you kind of get tunneled in and it's like everyone is using, but that's actually not the case. And also to remember, while we talk a lot about particularly opiates lately, fentanyl in particular, and maybe marijuana, that alcohol and tobacco still are sort of the #1 things that people are using. And so then it's not surprising when you look at pregnancy-specific data that really kind of holds up too for people who are pregnant. It's not that much different than the rest of the population. Again, we hear more about opiates and cocaine and methamphetamine, but they're actually in the minority of what people are using. So one of the things that in some of my duties here at UNC, one of the things that I'm on the Maternal Mortality Review Committee for North Carolina, and just looking at data from the 14 different maternal mortality review committees that exist in the country. History of or current substance use was present in about 67% of deaths. So it is a very common contributor to maternal mortality. And so a lot of the things that are seen, some of the themes when you look at the cases, is medication instability. It can either be psychiatric medications or the treatment of substance use disorder, having children removed from the person's custody, or people have a history of suicide. So those are all things that kind of weigh in to making this potentially a deadly thing for people who are pregnant or people in the postpartum time period. So looking specifically at North Carolina and then the US, Andre, do you want to say a little bit more about this slide?
Yeah, I'd be happy to. And I think, one of the really important things is that maternal mortality review committees are incredibly diverse around the country. The CDC has had a grant to help sort of standardize that, but still, like, not every state has one. And the way that the states do it is incredibly variable. So it makes it difficult to compare data from one state to the next. North Carolina has, I think, got a really fabulous one. There's been so much time and effort that has gone into it to really, and the abstractors for these cases just are heroes in the biggest sense, because it takes so much time and they so carefully go through to mine the data to really honor the person that has died. So there's a backlog. And so these are the most recent data that we have from 2016. There were 92 pregnancy associated deaths, and about a quarter of those did involve opioid overdose. And then when we're looking at those overdose deaths, a really striking finding was that half of them were never even asked about a substance use disorder. And so I think this just kind of brings us back to the picnic, which had a big effort in terms of just getting everybody to screen pregnant individuals for substance use and use disorders. And just a reminder that there is SBIRT that is out there, that screening, brief intervention, referral, and treatment. There is codes to bill that and to document that so that our hospitals can get that billing, and that we really need to be advocates to ensure that that is happening. When you take a broader perspective from the United States, there was recently data that came out that looked at the recent data from 2017 to 2019. Over 700 individuals died from complications of pregnancy or delivery. And 80% of those were deemed by the maternal mortality review committees as preventable. That means we could change the course. And I think that that is very similar to what we see in North Carolina. And then, of course, due to systemic racism, we have people that are Black or Indigenous people of color disproportionately represented in these deaths. And so figuring out new ways to really provide and prioritize care that honors and respects and believes patients is incredibly important. Next slide. Yeah. These are just some more data looking at from 2017 to 2020. These are data where you can see what types of drugs were involved in the overdoses during pregnancy, the pregnancy-associated overdoses. And as you can see, similar to what we see in the general population, pregnant people are not immune or protected in any way. So when we see more marijuana use in the general population, we see more marijuana use during pregnancy. Same with fentanyl and other synthetics. And just to say something about fentanyl, it is everywhere. During the COVID pandemic, the whole way drug supplies were manufactured and delivered changed, and fentanyl became incredibly prominent because the drug manufacturers and drug dealers realized that they could get fentanyl that is so powerful across the borders much easier because it is so potent, and then they could cut it later. And so we have patients, and Elizabeth can talk about this, that we have patients that come into our clinic thinking that they're just using methamphetamine, when in fact we take a urine drug test and they find out that they actually are also using fentanyl. So you can see the fentanyl deaths have increased. Heroin has remained pretty flat because it's hard to get in this country anymore. And then our psychostimulants, our stimulants are going up. And so we really do have twin crises. It's not just fentanyl, but it's also those stimulants too. And as you can see in this other slide, the B part, timing. So it's, we really need to do a better job making sure that we're taking care of our postpartum patients. I know I'm speaking to the choir here, but there's tends to be an uptick, that year, close to a year after postpartum for overdoses and suicides. And one of the things that I think is partially driving that is removal of children by Child Protective Services. Next slide, and I'll let you take it from here, Elizabeth.
So one of the things that we commonly do in my OB clinic and just in general, we know for opioid use disorder and pregnancy that medications, if that is something that the pregnant person is interested in, they are recommended. We have multiple choices, and we are definitely firm believers here at Horizons, as in other places across the country, that it is really about patient choice. There's not one superior medication. It is what works for your patient in that time. So we have methadone, buprenorphine, which comes as both a mono product or a combination with naloxone product, and then naltrexone, which is currently being, we're one of the many sites for a research study looking at naltrexone during pregnancy, so that we are able to establish safety and get some more information on that, because it's really good for pregnant people to have access to the full array of medications for the treatment of their opioid use disorder.
And if I could just add on just a little bit to that, just going back. So I think oftentimes methadone, methadone was the first medication we had to treat opioid use disorder. We know that for many years there was concerns about it because of the relationship to developing a neonatal opioid withdrawal or neonatal abstinence syndrome. And we did randomized double-blind trials to look at the relative safety and efficacy of methadone to buprenorphine. The data are strikingly consistent that there is less severe neonatal abstinence syndrome, meaning babies sometimes don't need treatment as often, and when they do need treatment, they need less medication treatment, and they stay in the hospital for a shorter period of time. That is not to say that we need to be moving all pregnant people to buprenorphine. There needs to be choice. The maternal outcomes between these two medications are strikingly similar. And there was just a New England Journal of Medicine article that was published that kind of replicated the randomized controlled trials that we've done in the past and upheld those data. And also, one of the take homes of that is that when we have patients that are new for opioid use disorder, buprenorphine can be a good place to start, because if patients don't have a good clinical response to buprenorphine, you have another medication to put them on, which is methadone. The other really important thing to know is that there is no longer the X waiver. So it used to be until, I don't know, about a month ago, that providers needed to have a special X waiver from the DEA to be able to prescribe buprenorphine. That is no longer the case. That means every provider that can provide medication, prescribe it, can now prescribe buprenorphine. And we suggest and recommend training around that so that you don't feel alone and you know what to do. If you have questions, I'm going to say that Elizabeth is a master at this, and so it can be really important as you have questions around, starting medications for people, or if a tapering is something that needs to happen for various reasons. And then the other piece is around split dosing. So right now we have a lot of education and advocacy going on to help patients get the medication the way they need it dosed for them. And so methadone works best when it is given at least twice a day. So you take the total dose and you divide it in half, sometimes 3 times or 4 times, and you get much better clinical response where you don't have the sedation that sometimes we see with a big bolus dose of methadone, and it can help patients even out their intrauterine environment and also allow them to stabilize in their recovery much better. Oh, and also too, one more thing, and then I'll be quiet, is that in terms of the injectables, those are actually under investigation right now. So there's a MOMS study that's a multi-center trial looking at sublingual versus injectable. So kind of stay tuned for those relative safety and efficacy data. Thanks, Elizabeth.
Absolutely, thank you. So just thinking about the shared decision-making tool, this is what we've followed certainly in clinic when I'm seeing patients. It's really talking through, sort of Andre did a beautiful description of the different medications that are available, but it's really being able to have a conversation with patients about what's going to work best for them. I've had patients who say, I cannot drive because methadone needs to be delivered at a particular type of clinic, an opioid treatment program, an OTP, where people need to go daily and get their medication. And for some people, that's really supportive to have that structure. And for other patients, that's a barrier because it's hard for them to get there. And so there's lots of things to think through. So it really is, the bottom line is helping the patient make the decision that is best for that family at that time. And so I think that's just the important thing to think about.
Yeah, the other things to think about too that are on the shared decision-making tool is around breastfeeding. We have very clear data to show that breastfeeding is compatible with methadone and with buprenorphine. We know that there's very incredibly tiny amounts of these medications that are in the breast milk. And what's been found is an association between breastfeeding and less neonatal abstinence severity. So, and we think it's the act of breastfeeding and not necessarily the actual amount of medication because it's so tiny. And if you'll think about buprenorphine, that is only sublingually bioavailable, that if the baby swallows it, they get even less of the medication, of that tiny amount of medication. So please, please help us promote breastfeeding with our patients.
Yeah, thank you, Andrea. And that's a really good point. And it's less so than when I first started working at Horizons 10 years ago. We used to get a lot of messages early on that people at WIC and other individuals were discouraging breastfeeding, pediatricians, people who worked at WIC, but that has seemed to have gone away. It still does exist some, and it's a question that I get all the time. Moms are always asking that question.
Also, too, with the pain management, you can keep it on that slide, it's fine. But with pain management, to make sure that patients are being believed that they have pain and that they should not be stopping either their methadone or their buprenorphine before they go in for labor and delivery. They need to be able to have their continuous medication regimen throughout labor and delivery and into the postpartum period. And in terms of pain management, there are the specialized protocols to help support pain management acutely as well as chronically.
Yes, thank you. And that's another question that I get often from the people that I take care of is, will the epidural work? A lot of reassurance that yes, if you would like an epidural, you may have an epidural, and yes, it will work for pain management during labor. That is a very common question. The other thing that comes up a lot for me in clinic with the people that I'm taking care of is what's going to be happening with baby if the person has decided to particularly take buprenorphine or to take methadone. This is people's another like really primary concern. So what has been called neonatal abstinence syndrome, we've moved towards neonatal opioid withdrawal syndrome. The big thing here is that it is a known entity. It's expected. We kind of know how to manage it. And so it's some of the sort of highlights of it. We get some neurologic excitability, some GI dysfunction, nasal stuffiness, sweating, sneezing. And a lot of it, if you look at some of the older methods of assessing severity, if you look at the symptoms, a lot of the symptoms are what babies do. Babies yawn, babies sneeze, babies get fussy. Like these are all things that babies do that can just be exacerbated a little bit if the baby's withdrawing. I mean, it can get to be a more serious thing. It is, but that is not the common course that we see. So this is fairly old data, actually, and just really the take-home message from this is that if you start to look, if you were to look at this is infants with diagnosed NAS or NOWS, and in North Carolina, it tracks exactly with the reported opioid use during pregnancy, which makes complete sense. And so it just really spiked up. 2011, 2012, that is really when we were seeing more actually like oxycodone. That was before heroin really came surging onto the scene. But it makes sense that if more moms were using, then more babies would be impacted by that. This is the data that Andrea was talking about in her research. I don't know if you want to talk about this.
Yeah, we don't have to spend much time on it, but this was our randomized double-blind trial for looking at the relative safety and efficacy of methadone versus buprenorphine for prenatal treatment of opioid use disorder. And what we found in this randomized blinded study that used flexible dosing was that there weren't the proportions of babies that needed to be treated for neonatal abstinence syndrome or NALS was not statistically significantly different. When you look at open label studies or observational studies, sometimes you will see a significant difference with fewer numbers of buprenorphine babies being treated for neonatal abstinence syndrome, but under blinded conditions, that was not the case here. What was different, and whoppingly statistically significantly different, was when babies had been identified and needed to be treated for neonatal abstinence syndrome, those that had been prenatally exposed to buprenorphine required significantly less morphine to treat their neonatal abstinence syndrome and then stayed in the hospital significantly fewer days. And what was also important was that in terms of our maternal outcomes and delivery outcomes, they were very similar. And so this was really the first large-scale study to ever say methadone is relatively safe and efficacious. And also buprenorphine wasn't worse than methadone and provides an alternative and a choice for patients that have opioid use disorder during pregnancy.
So one of the other things that that I know I get questioned about a lot in clinic, and if you're working with this population, you might hear this as well. So the people that I take care of are often worried about the dose of their medication and how that's going to impact the baby. And logically, I understand I get a lot of requests for weaning down, cutting down the dose of buprenorphine as they're getting ready for delivery, because it makes sense that people think that's going to make the baby have an easier time. And so we do a lot of education about the fact that there is no dose response that has been found. Relationship to how much medication you're taking and then how baby does related to that. However, smoking is something where there is a dose response. So if we can get moms to cut down, and the way I tend to approach it is I tell the people that I'm taking care of, I'm like, in a perfect world, of course, I'm a nurse practitioner. I would love for you to quit. I would love for everyone to quit. I don't want anybody to smoke. But I'm also a realist, and if you can cut down, it can make a huge difference. And so I've actually had a lot of patients have really good success at cutting down prior to delivery. Doesn't always hold once they've delivered, but we've done a lot of really strong work, I think, in getting people to cut down on their smoking, because this is something really tangible. They feel like this is something I can control and something that I can do to help take care of my baby. And we have a lot of good success with that. So we talked a little bit about the assessment. So traditionally there were instruments or scoring was happening, and then if a baby reached a threshold score, they would get treated. And this has kind of like fallen away out. I mean, there are hospitals that are still using this approach. The most common scale used is the Finnegan. So there are some hospitals who are still doing this, but this is sort of falling out of fashion. Sounds dramatic, but we're sort of moving away from this into a new approach. And so actually this it's some great data from our colleagues, our PEDS colleagues here at UNC. So they actually duplicated a QI project that was done up in Boston. And there's an approach called Eat, Sleep, Console, which really has done amazing. The data, and I'm sorry I don't have like the graph for you, but I remember the first time I saw the data, it made my jaw drop. So they sort of did a couple of phases where first they decided, as we talked about nicotine being an issue, the first thought was, hey, are we giving babies morphine for a nicotine withdrawal? Let's not do that anymore. If mom is a heavy smoker, let's not assess that baby for the first 12 hours of life and give the nicotine a chance. So that resulted in fewer babies getting treated. But then as they really got into doing Eat, Sleep, Console, the number of babies getting treated and the amount of morphine that is required has really it's dramatic. And I will say that UNC has been doing this for several years, and in all that time, I think every year I have maybe 2 or 3 babies that get medication and they get 1 or 2 microdoses. So that's the other big difference, is that with the traditional approach, babies would get a weight-based dose of morphine. There are other medications that are used, but they'll use at UNC, they were using morphine, and it was weight-based. And then you get this wean, which then means you're in the hospital for 10 to 14 days. Now with these microdoses, if the baby's a little fussy and they do all of these, they swaddle the baby, they turn down the lights, they turn down the noise and do all those things, and baby's still really fussy, they give a microdose and then let the baby reset and then they reassess. So it really has made a huge difference, and I can't tell you the difference it has made with our moms. They are so excited and so happy because babies are going home in 72 hours, which is just fantastic.
Yeah, and I think an important part of that model too is, I love what Carl Seashore says, mom is the medicine. And so before babies get treatment, there's a huddle that happens, and they really strongly encourage parental involvement. So that skin to skin, even if maybe mom's not there, maybe there could be another caregiver that's there, but there is this belief and support and empowerment of the parent to support the dyad.
Yeah, thank you. Yeah, I love the mom is medicine. I love that phrase. Yeah. So Andre already talked about this. Really, we want to have moms, if breastfeeding is the choice that they want to make, we really want to support that decision because we know it's important. A lot of the patients that we take care of have barriers to breastfeeding. I mean, this exists for all people, but can really be emphasized in our patient population. If a baby is having some difficulties with withdrawal, any fussy baby can be hard to breastfeed because it's hard to get them to palm, it's hard to get them to latch. All of those things can happen. We still know that, as I mentioned before, there's still people in the community who discourage people from breastfeeding. I have had patients who told me that their grandmother, their mom, their aunt, somebody has told them that they can't do it because of the medication they take or some other reason. So there can be barriers, and we just need to be mindful of that.
And sometimes our nursing team needs education too, because sometimes they will not overtly, but a little more subtly discourage breastfeeding by saying, oh, I'm doing something with the baby now, you have to come back. And that can create an additional barrier. And also too, trauma, and I know Elizabeth, you'll talk about this in a moment, but sometimes patients, because of the trauma that they've experienced, have a very difficult time seeing their breasts as this nutritive agent, and help and food for their babies.
Yeah, absolutely. So transitioning into what you all focus on all the time, so the postpartum time period. We do know that for a lot of our patients, the postpartum time period is a high-risk time for return to use. It can be pain related to delivery, changes in relationships, the increased stress. So all of the things that anyone who is a new parent can experience can just become exacerbated. And if you are someone who does not have coping strategies that allow you to kind of get through this, or a good support system, return to use can happen. And as Andre mentioned before too, a lot of our patients are having interactions with both child welfare as well as courts and criminal justice agencies that really make this time that much more challenging than for other people. We also know that this is a time when mood disorders can occur for anybody. We also know that for people with a history of substance use disorder, their risk for postpartum mood disorder is higher. A lot of the people that we take care of have some level of depression and anxiety, and also trauma. All of those play into the fact that they could be super high risk for having a postpartum mood disorder. And so one of the things that I do in my clinic is I usually try to see someone within 1 to 2 weeks after they deliver and really keep a close eye on them, and doing the Edinburgh or some other scale and making sure that people have access to the support that they need to get them through this time. Andre, I don't know if you want to talk a little bit about the
Yeah, this is just a reminder that CAPTA and CARA, so CAPTA is our Child Abuse Prevention Treatment Act, is that federal statute that funds child welfare in all of the different states, and there's a system to report child neglect and abuse. And their laws are pretty broad and non-specific, and so states have a lot of leeway and authority into crafting their specific ways that they address child protective services. And then CARA, and CAPTA gets reauthorized. The last time it was reauthorized was a part of CARA, which is the Comprehensive Addiction and Recovery Act in 2016. And it was in that time that a plan of safe care was initiated, which asks all of the states that receive CAPTA funding to provide aggregated de-identified data of what they called substance affected newborns. And there were no definitions for substance affected or withdrawal or what active use during pregnancy was. And it's created incredible variability in different states and how they have designed themselves in order to respond to the requests for data for these things. And so one important note is that for diagnosis of neonatal abstinence syndrome does qualify children for early interventions. And you can see this in North Carolina. There's a little link there because we really want early intervention. We want help for both the parent as well as the child as soon as humanly possible to help get them off on the right foot. One of the things we know about neonatal abstinence syndrome, or NALS, is that it can create a dysregulation between parent and child. And as soon as the parent can really understand child's cues, and then the children and learn how to respond to them consistently, this can really be a strong foundation for that supportive bonding that needs to happen. Next slide. And so some of the things for you to think about, so I invite you to really think about what happens in your hospital settings. There was a Supreme Court case back in 1994 that said that when pregnant people come in to deliver their baby, they have to have informed consent before a urine drug test or any other biological matrices can be taken from them. We know that that doesn't happen, that people's rights are violated every day. So, this is an opportunity for you to think, are we really giving informed consent before a drug test is done? And then also thinking about those drug tests. A lot of times there will be false positives or false negatives, and you really need a confirmatory test that is done by a lab like GCMS to determine what type of substance and how much is in that biological matrix that is being tested. Another thing too is, again, we see and we hear about patients' confidentiality and privacy being violated every day, because there's this sort of free flow of information sometimes with law enforcement or child protective services that does not have a release of information. So again, these are just things that we have heard of around the United States, and so things for you to think about. And then also thinking about drug testing and reporting and understanding our own state laws and where we practice. And knowing that neither CAPTA nor CARA say you must do drug testing. That is not in those pieces of legislation. So there are universal screening protocols that can be done. There are different types of protocols that are being used around the country that are a very much more supportive approach than a punitive approach. Next slide. And this is an example. So the state of New York has determined and interpreted their laws to say that a positive toxicology alone does not support a report to seek child protective services. And this is really important because of the false positives and false negatives. Just having, if you look at the bottom, just having a positive drug test or screen does not diagnose a substance use disorder. All it tells you is that on this test, there is the presence of a metabolite of a drug. It also doesn't inform anybody about someone's ability to parent or their frequency of their use or of child risk and safety alone. You need sort of a composite approach to really look at how safe is it for that neonate or infant to go home with that parent. You can continue moving.
All right, so I don't think that it's pretty rare that Andre or I give a talk where we don't discuss trauma because of the prevalence of it in our population. So this is just an example. So every year at Horizons, we collect data that we have to report to the state. And so this data, a lot of it is collected during people have only been here for a day or two. So if they're brand new coming into our program, they don't really know us that well yet or trust us that well yet. And so in context, when you think about that you have such high reports of some kind of trauma, whether it is being homeless, whether it's having emotional abuse, physical abuse, sexual abuse, when you think about it being that high, so 86% of all of our new clients in this period of time report at least one form of violence. It really comes to light usually when people have been here for some length of time and they have been able to trust us a little bit more. It's much closer to 100%. The rates of trauma are really high. This is in the literature as well. That the rates of trauma in our population are much higher than the general population. So why do we worry about this? We know that post-traumatic stress disorder, if you look specifically at that, it really impacts pregnancy and parenting. For people who are pregnant, they can have shorter gestation, which of course then would lead to lower birth weight and can cause difficulty with attachment. And then we also know, particularly in the postpartum time period, there's a much higher rate of suicidal ideation and other psychiatric comorbidities with PTSD. So it really is something that we need to be paying attention to and be thinking about, and also be mindful. This is something that we talk about in my clinic all the time, is really thinking about how patients may present to us the first time they come in. And what we see a lot over time, I don't expect people to trust us the first time they meet us. Because the other thing that I will say is, the one piece of trauma that was not on that slide before this was trauma from the hands of healthcare, which is far more prevalent than I want to think. It's really hard to think about that. But the stories that I've heard from my patients, how they're talked to, how they're treated, how their family is treated, it is really unnerving to me sometimes. So I don't expect people to trust me when they first come in, but it's really being mindful of that and earning people's trust and setting up an environment where they can sort of relax and feel good about coming and getting care. Andre talked a little bit already sort of about some stigma and discrimination that our patients are facing on multiple fronts. We do know that when you start thinking about an intersection of different people's identities, that trauma, stigma, and discrimination often occur and are more intense at these intersections. And so if you think about, race, class, ability, gender identity, language, religion, and then you add on to that substance use disorder and any other identity that may come with that, we know that that's where things can occur. And it's really, really important that we just acknowledge that these intersections exist and have the knowledge that there is the chance that stigma and discrimination are just much more intense in these areas so that we can be sure that all of our patients are heard. So talking just a little bit about how these things show up. I mean, I think one of the biggest ways that particularly stigma and discrimination show up is that it prevents pregnant and postpartum people from seeking care. I know in some of the early laws where there was, Tennessee was criminalizing substance use during pregnancy. I really clearly remember hearing a story on NPR where they interviewed a mom who had shown up, had no prenatal care, shown up for delivery, and they did a toxicology screen on her, and they took her baby from the hospital, and she ended up going to jail. And Tennessee ended up, Andre, how quickly they sunset that law? Fairly quickly, because
2 years, yeah,
Yeah.
and that was only because it was written into the legislation, which was incredibly unusual. But that was because advocates were so worried about the legislation that hurt and harmed patients.
Yeah. And so it just showing that it ended up with people just not getting care, which then you think of all the ways that that increases maternal and fetal morbidity and mortality just by not getting prenatal care, and all the ways that that shows up. The other thing just to think about, this is just a graph looking at policies that are targeting pregnant people using substances starting from 1970, and this stops at 2016. You know, some of these things are, not all of these policies are negative. Some of it is priority treatment for people who are pregnant. But the idea behind this is really like the very large number of policies and laws that people are trying to put in place to mind the bodies of pregnant people who are using substances. It is pretty overwhelming. So it's a population that gets a lot of attention. I don't know.
Yeah, I just want to add, so Sarah Roberts has been doing this work for many years, and she has a number of publications. If you haven't seen them, they're really interesting to look at. And one of the big conclusions that she has is that categorizing policies into, harm, punitive or supportive. So a supportive one would be, for example, getting people priority treatment for pregnant women. Well, what she's found is that all of the policies uniformly are either bad or have no effect. That even the ones that we think of as having supportive effects don't. So it's really an opportunity to think about, okay, we know we have lots of data now to show what's not working. So we really need to take a step back and have some evidence-based policies move forward that could better support and get the outcomes that we all want, which is healthier children and healthier parents. Next slide.
So another place that we know, Andres touched on this a little bit. We know how this shows up is in policies removing children from their parents. So as Andre mentioned, with all the different states, so there's 50 different interpretations of the CAPTA legislation. And then in North Carolina, there's 100 different interpretations. Each county has its own interpretation of the way that North Carolina has chosen to interpret CAPTA. So we know that foster care placement is far too common and that it really disproportionately impacts children who are Black children, children from indigenous populations. They're really, really disproportionately impacted by foster care and then going into adoption. And then I know that you guys are probably fully aware of this. We know that, we all have our own bias, and healthcare professionals, as I mentioned, so many of our patients are traumatized by the healthcare system. We'd like to think that we're immune from this, but we're not, and we really have the same types of implicit bias as the regular population. I think we really want to believe that we're not there, but we are. I'm glad that there are more conversations happening about this in the last few years than have been previously, but I think it's really important for us to be thinking about. And then another place where this shows up is in treatment disparities. And so we know there's been a lot of research that's looked at access and retention to treatment, and it differs when you look at race, where non-white patients are less likely to be retained in treatment. They might be less likely to receive treatment. We also know that the overdose deaths have been rising at much higher rates amongst Indigenous Americans and African Americans and amongst the white population. And so these disparities really are a problem and exacerbate the issues that we already see in healthcare. So it's really, really important that the high standards of evidence-based treatment that we have are available to all people. I don't know, Andre, if you have anything you wanted to add to that.
That's great.
Okay. So what can we do? I think advocacy, that's something that we believe strongly in here, which really, I can't overemphasize the importance of listening to people with lived experience. They need to be involved in our policy making. They need to inform how we are doing research. And so we really need to be listening and changing the framework. So thinking and having policies that address social determinants of health. I'm really moving away from punitive policies, as Andre mentioned, because they really can be detrimental. Focusing on harm reduction, that is something that I do all the time in clinic. Even just when I talked about the smoking piece, that's a harm reduction strategy, right? Getting someone to, I want you to quit, but let's get you to cut down. But really taking that stance in a lot of different ways and meeting people where they are and working with them over time, I think is really, really important. Another thing that we talk a lot about here is changing the conversation. So it's really easy to question, like, why is this person using substances? This person is pregnant. Aren't they worried about their baby? It is easy to see how one might slip into that mindset, but really sort of flipping that and thinking, hey, what happened to this person? What has happened to this person to get them to where they are? I think that is the most important thing. And to understand, we praise people all the time, no matter where they are in their use disorder framework. Just coming into clinic to get prenatal care, that is a huge win. Even if they are unstable in other areas, just coming for care, that's huge. And feeling safe in that respect is really, really important. And then I think education, it's educating yourself, it's educating the community. If you don't know about the perinatal harm reduction website, they have a lot of really, really wonderful education there, a lot of things that you can give to patients, for yourself to learn, handouts. It's a really, really great website that has been very thoughtfully put together. It helps us kind of think through how best to support our patients. And then really considering patient-centered and trauma-informed care practices. This is something we talk a lot about here too, just being trauma-informed from the time that someone comes through the door all the way through. It's really, really important. So when we think about during the prenatal time period, it's really getting patients the support that they need. When patients go to deliver, getting the support that they need, understanding the role of trauma, keeping families together once patients have delivered, and then getting the community to really rally around our patients in the postpartum time period. I think we've got a little more time. So just a little bit about our program. We have the OB clinic that I run Monday mornings and all days on Thursdays. And then we have a larger program that does residential treatment where women can come and live for up to 9 months with their children. They participate in group. Andre teaches a wonderful group. I teach a group as well. And they have therapy both for themselves. And we have an amazing child therapist, Yvette Horton, who works with the dyad. They have case management. It really is a wide array of services that are available to people who want to come and do residential treatment. It's a pretty amazing program. We have several sister programs across the state. So we are not the only game in town by any means. But it's pretty comprehensive what we do. I don't know, Andrea, if you have anything else.
We also provide psychiatry services with Dr. Julia Nur and her residents that come and train. We provide transportation, and we have a child development center, so that one of the big barriers to treatment often is that women can't bring their children to treatment, either outpatient or residential. And so the really beautiful thing about all of the sister programs that we have is that women can bring their children to treatment. Up to age 12, there's still rules, unfortunately, that they can't bring their older children because that still is a barrier. And then our 5-star child development center has staff that are trauma responsive and understand how to work with our parents as well as the children. And all of the children can be screened and assessed and receive PT, OT, what a speech language, all those like things that they need, pretty much at our child development center, which is amazing because then the parents can come in and hear and then learn and then practice at home, and then it's reinforced with our maternal child therapist. So it really truly is that dyad, because we want to break the intergenerational cycles of addiction and trauma. And so this is one way we.
All right, I don't know if we've got time for questions. I'll stop sharing my screen. I don't know if people have questions. I haven't been looking at the chat, so I don't know.
We
did
have
a little bit.
Thank you so much for this. Yeah, so I'm going to ask the first question in the chat, and then do feel free to come off mute or to continue using the chat. First question, do you have strategies for healthcare team members coping and thriving?
So I responded, but Elizabeth, you can please add on. So in 2014, we created a self-care toolkit that we give all of our team members. And I'm happy to share it if anybody wants that self-care toolkit. It's got a whole bunch of different links to things, but it's also got some tools in there to look at how do we cope with stress, and are those coping mechanisms maybe stressors in and of themselves. It goes through sort of a mind body balance. There's just a whole variety. There's even an emergency self-care plan that a number of our staff will use, because it's so hard once you get frustrated and burned out and frazzled to even think of what would make me feel better, so they can pull this thing out of their desk. To do that, we've got 50 ways to take a break. And then I think the other thing that Horizons does, and I know that this isn't always feasible in an incredibly busy and hectic healthcare setting, but we hold time and space for people. We have an open door policy. I don't know how many people come see Elizabeth every day, but like, we hold time and space for people to feel frustrated, to be like, oh my gosh, this patient's driving me. Know that our patients can exhibit through the illness, the symptoms of their illness and the signs of their illness. Those can be frustrating things, and we want to be able to like, let's vent, let's get that out. Okay, now let's focus on what are those behaviors trying to tell us. Sometimes it's trauma being expressed. Sometimes it's like their illness has just sort of bloomed in a different way, and we need different solution-focused strategies. Elizabeth.
Yeah, no, I think that's the only thing I would add, is that sort of my perspective as being the sort of one of the only, we have two just healthcare oriented people here in this wonderful large organization. And one of the things that I definitely love and value from my behavioral health colleagues is the idea of sort of supervision, which is what Andre's talking about, that moment to kind of take a pause and decompress and be mindful of, an interaction with the patient can bring up stuff for you. And so being mindful of doing your work and not bringing that into the interaction as well. But that's one of the things that I definitely value about here, is that everyone is really supportive and giving people that time and space, because the work can be really hard, but it can also be amazing. I had an interaction like that this morning, that I turned to the med student who was with me and I said, you see, this is why I do this every day. Because it was just like one of those, the clouds parted, the sun shone. It was just amazing. And I was so glad that he got to see that. And so those things are good reminders too.
And I think the other thing, you are what you think, right? So, and I'm a firm believer that a foundation of recovery is gratitude and appreciation and focusing on the positive. So most of the meetings, not every meeting, but most of the meetings that we start a round of gratitude, and it can be something quick, but I think that sets, and especially if you're going to have a difficult conversation, or like you're talking about a really challenging patient, it's good to start out with gratitude. What are the strengths that we see in this patient before we start talking about the other things that we're saying that aren't that we're not identifying as strengths? So
that's so powerful.
Any other questions? We just have a few minutes left. We really thank you so much, both of you, for spending time with us and for sharing this excellent presentation, which, yes, as we've noted, well, thank you, was recorded, and we will share it. Our next community of practice is coming up March 23rd, and it's on Implicit, which is a really cool program led by Family Medicine that provides mom-baby dyadic postpartum care, which is really cool. So I hope you all join us for that. And as always, our team is here to support and serve. So let us know how we can be helpful to you in the work that you're doing. And as we end it, I hope everyone will get a chance to get this little sneak peek at spring today. So maybe practice a little bit of self-care yourself and go outside and take a breath and look at some flowers. Thank you again so much, and hope everyone has a wonderful rest of your week.
Thank you.
Thank you, everybody.
Thank you
Take
again.
care.
Thanks, everyone.